So my name is Amish Raval. I'm a professor of medicine at the University of Wisconsin School of Medicine and Public Health. I'm also the chair of the Cardiovascular Regenerative Medicine Focus Group there and the director of the ST Elevation Myocardial Infarction Program, and also the principal investigator of the CardiAMP heart failure trial. In patients who've had myocardial infarction, the importance of this is that following the MI, there's an injury. And with that injury also includes some vascular deficiency. The combination of both lead to a self-propagating process called adverse remodeling. And that leads to chronic inflammation, fibrosis, as well as depletion of blood vessels. And so we know that process can lead to decreased contractility, and the clinical condition that we're familiar with is called congestive heart failure. In previous studies, the use of autologous bone marrow mononuclear cells have been used in treating this condition, and intramyocardial delivery hasn't shown some initial outcome improvements. But there are some patients that seem to respond better than others, and those patients seem to have certain well-defined cell characteristics in that bone marrow population. So the motivation behind the CardiAMP heart failure trial was to select out those patients and directly test in that patient subgroup whether or not autologous bone marrow mononuclear cells could be delivered intramyocardially and whether that would manifest in improvements in outcomes. So the CardiAMP heart failure therapy consisted of a small volume bone marrow aspirate, approximately 6 milliliters, done in an outpatient setting. If the patient then qualified based on bone marrow potency cell characteristics, they then came back for a follow-up procedure where 2 weeks later or so, where 60 milliliters of bone marrow were collected. I should backtrack and say that we're talking about chronic ischemic heart failure patients whose ejection fractions are between 20 and 40%, who are New York Heart Association class 2 or 3, and who cannot walk more than 450 meters but can walk more than 100 meters on a 6-minute walk test difference. So the process includes that small volume bone marrow aspirate, then it includes the larger volume bone marrow aspirate if they qualify. Following that, in the same session, it's a personalized sort of patient-oriented point of care approach. In the same session, the patient's turned over on supine on their back and undergo a left ventriculography with a pigtail catheter via femoral artery approach in biplane fluoroscopy. And using echocardiography as a roadmap to reference, we then inject the bone marrow cells, their bone marrow cells, autologous, into up to 10 locations in the border zones surrounding the infarct location. Now, after the ventriculography, there's a randomization. So those in the treatment group get the cells injected, but those in the control group undergo a procedure control wherein a scripted sort of deception is occurred to make the patient unaware and to preserve blinding. So no actual injections are occurring. That said, the control patients do get femoral access and they do get ventriculography. So there is some invasiveness to that. But then ultimately, they're followed in a double-blinded fashion. The trial design is a 3-to-2 randomized control clinical trial, and it was done across 25 centers around the country, both the U.S. and Canada. Ultimately, there was an open-label rolling cohort phase that was initially done, and that was published previously, just to demonstrate that we could establish best practices. And then after that, the randomized phase took over. In the randomized phase, we learned that about 38% of patients who were otherwise eligible to be enrolled screen failed on the basis of that cell potency analysis. That cell analysis was done using a flow cytometry-based method at an independent core lab. Of the remaining patients that were then included into the trial, 303 were screened. But after about 6 years into the trial, which started in 2018, the Data Safety Monitoring Board put a pause on the trial, and the sponsor ultimately stopped the trial in light of the fact that one of the primary endpoint tiers, 6-minute walk test difference, did not meet its primary endpoint. So in addition, we had real struggles with the COVID-related enrollment that made everything very slow. The primary outcome of the entire trial, which was normally supposed to have a planned sample size of 250 patients, ultimately only had 150 patients at the time of trial stop. the primary outcome was a Finkelstein-Schoenfeld win ratio method to compare patients who received cells versus patients who didn't. And it's a very powerful method. It allows you to measure composite outcomes and compare those patients receiving treatment against every other patient in the control group. And by making the tiers such from importance, there was a hierarchy to that. So tier 1 hierarchy was patients so death, left ventricular assist device placement, or transplant as a kind of a cardiac death equivalent. Those are all tier 1 events. Tier 2 events were the non-fatal MACE events, which included MI, stroke, and heart failure rehospitalization. And then the tier 3 events were the 6-minute walk test difference. So now when you're trying to compare these, you kind of go in order. And what we learned is that the win ratios was favorable. The wins were favorable for the treatment group for the tier 1 and tier 2 events, but were not favorable for the 6-minute walk test difference. So the overall win ratio was only 1.01, which is close to 1. And that, of course, was not statistically significant. Now, mind you, during this trial period, it was extraordinarily challenging to standardize the 6-minute walk test difference across all the centers. And we also learned in the experience that there was quite a bit of variability in 6-minute walk test times or distances between centers, but also within patients who had sudden jumps in 6-minute walk tests. And we think by applying a restriction to their walking in as a point of entry, confounded the results on the back end in terms of that walk distance. So that might be the explanation as to why the MACE events were going in one direction, whereas the 6-minute walk tests were going in the other. That all said, we looked at a subgroup of those patients, about 50% of the patients who had a NT-proBNP level greater than 500 picograms per milliliter, or BNP level greater than 500 picograms per milliliter. So a sicker subset of that. And we learned that within that subset, that patients had wins across the entire column for the tier 1, tier 2, and the tier 3, including the 6-minute walk test difference. So that win ratio improved or got better, but still was not statistically significant, likely related to that same variation that we were observing. But if we, in a pre-specified secondary outcome analysis, we replaced the tier 3 events with a different outcome measure, and that is Minnesota Living with Heart Failure Questionnaire. And that's a quality of life measure. And so if we look at the same tier 1 and tier 2, but now we have a different tier 3 event, now the wins were much more favorable for the cell treatment group across all tiers, with a win ratio of over 2, which was statistically significant. And in fact, if you kind of boil it down, the delta in terms of the absolute reduction in all-cause MACE events was about 17%. So that's a number needed to treat of 6 patients to prevent a MACE event. And so we think that's a really important outcome. Now, that was only 50% of the entire study population. And of course, the trial was halted shy of its intended goal. So that's not definitive, but it is definitely compelling. And so the motivation behind, so this has created a motivation to have another trial to only include those patients with elevated NT-proBNP or BNP as another way of identifying patients who may respond better to autologous cell therapies. Yeah, so that second trial, the CardiAMP Heart Failure 2 trial, is now FDA approved and is going through the trial sites. Our site is onboarded, but we're probably not going to enroll until the summer. But it is initiated in that sense. Yes, it's active. So I think the main take-home message is, first of all, is that the 6-minute walk test, distance ratio metric rather is a challenging metric in this sort of a current day practice. And if you're trying to enroll patients across multiple centers, like 25 centers, it's really extraordinarily challenging to make sure that it's all standardized. And then it didn't help much that we had a global pandemic, which really altered things. So I think having a much more simplified patient-centered metric, it's important to have a patient-centered metric like 6-minute walk test, quality of life, because if you only focus on MACE events and so forth, you're not really taking into account, the patient's perspective. But a quality of life measure is a much easier measurement to get at. The second thing is we did realize that there was a lower than expected event rate in overall. And so really isolating those patients that have an NT-proBNP level that's high really kind of focuses in on those types of patients that are likely to derive the best benefit. I think overall the message is that still there's a very large population of patients who are untreated and undermanaged, and we need to find important therapies. So patients are asking, and we need to come to the table with the offer options. So those are I think the main messages.